I want to tell you about the moment I nearly got this wrong. I just finished reading the heart data from part 1 and the finding that these GLP-1 drugs protect your cardiovascular system in ways that have nothing to do with weight loss, which is genuinely exciting information. So I kept digging, first into the brain, then into cancer, and then I realized I was about to make exactly the mistake I criticize in other videos. I was about to lead with the exciting result and quietly leave out the one that didn't fit. So before I share what I found, I want to be honest about both. Hi, I'm Sinead, and this is the pause point. So in this video, we are starting with the brain. And if you haven't seen part 1 yet, it's linked below, because the heart findings in that video set up everything that follows in this one. So it's worth watching first. Also, as usual, all the claims made in this video are referenced to a named study or a peer-reviewed source, and all the links are in the description, including, and especially, the findings that didn't give us the results we were hoping for. When I started looking at the brain research, I found something that had been building for years. Large observational studies kept noticing something that was hard to ignore. People taking GLP-1 drugs seemed to develop dementia at lower rates. And that sounds pretty exciting. But here's the problem. Observational studies can show us that two things are happening together, but they can't tell us that one caused the other. Also, people who take these drugs differ from one another, and from those who don't, in dozens of ways. Income, health access, lifestyle, other medications. To find out whether the drug is actually responsible for an outcome, you need randomized clinical trials, which are the gold standard. So that's what the researchers did, and that's where it gets complicated. The first paper I found came from Imperial College London. It was a trial testing liraglutide in people with mild Alzheimer's disease. And at first glance, the results looked really encouraging. People taking the drug had nearly 50% less brain volume loss on MRI scans, and an 18% slower decline in cognitive function over 1 year. And honestly, when I saw those numbers, I really wanted to believe them. But I did what I think you always have to do with a result that sounds as good as this. I looked closer. And that's when I found a really important caveat. The trial's primary endpoint, the main outcome it was designed to test, was a measure of glucose metabolism in the brain. And that endpoint was not met. The numbers that made the headlines were secondary findings in a small trial that wasn't built to prove them. Then came the bigger test, the one I thought would settle it. A much larger set of trials called EVOKE tested semaglutide in nearly 3,800 people with early Alzheimer's, and that was published in the Lancet. And the result? It didn't work. Semaglutide did not slow Alzheimer's disease. On the main measure, a standard scale of dementia progression tracked over 2 years, it actually proved to be no better than placebo. Even though it had improved some biomarkers, it simply didn't change the path of people who already had the condition. So we have one trial showing real promise and one large trial showing nothing. So what do two trials pointing in opposite directions actually mean? The interpretation that the researchers themselves landed on is that by the time Alzheimer's is established, it may simply be too late for these drugs to have an effect. But that's a hypothesis. It's not yet validated. And that's actually where this gets really interesting for women in midlife, because the decades before symptoms appear are also the decades when many of the biggest risk factors can still be modified. Insulin resistance, visceral fat, high blood pressure, chronic inflammation. So maybe the more interesting question isn't whether these drugs can reverse Alzheimer's. Maybe it's whether improving metabolic health earlier in life could influence the risk later on. And that's a very different question. It's the difference between fighting a fire and never letting that fire start to begin with. So when I step back from both the heart findings and the brain findings, something kept connecting them. The heart benefit that didn't depend on weight loss, the brain protection that seems to matter most before disease begins, they keep pointing to the same idea, that these drugs may work largely by improving the metabolic terrain your body operates in, calming inflammation, restoring insulin sensitivity, reducing the visceral fat we covered in the belly fat video. And there may be one more place that terrain matters, and that's the cancer risk. This is the section I had to sit with the longest, because when I read the headline, 30% reduced breast cancer risk in women using GLP-1 drugs, I wanted it to be exactly what it sounded like, because I'm on Tirzepatide. Of course I wanted that number to be real. And the honest answer is, it might be, but it's not what the headline suggests. So here's what the findings say. At the 2026 ASCO Cancer Conference, researchers at the University of Pennsylvania presented data on more than 111,000 women aged 45 to 80, overweight, receiving regular breast screening. Women using GLP-1 drugs were about 30% less likely to be diagnosed with breast cancer. 30% sounds enormous. So here's what it actually means in real numbers. 1.6% of the women on these drugs were diagnosed, compared to 2.3% of those who weren't. Now that is a real difference, but it's less than 1 percentage point. Put another way, we're talking about roughly 7 fewer cancers for every 1,000 women. That's still important, but it's a very different headline from 30% lower risk. And this is exactly why I think we need to be careful with medical headlines. The biology is plausible. Body fat produces estrogen, high insulin fuels cell growth, chronic inflammation creates an environment where abnormal cells thrive. A drug that addresses all three could, in theory, make the body a less hospitable place for some cancers to start. But, and this is important, this is still a very early signal. These are observational studies and not randomized trials. And the researchers couldn't account for everything, including exactly which drug women were taking, what dose they were on, or even how long they'd been taking it. And another study, presented at the same conference, found a more modest 16% reduction in women at higher risk, while at least one long-term analysis found no reduction in breast cancer at all. So I wouldn't start taking one of these drugs because you think they might prevent cancer. That's not what this evidence is telling us. What it tells us is that there's a question worth investigating, and that distinction matters, because this is where GLP-1 research gets really interesting. The heart, the brain, cancer, different organs, different studies, but potentially the same underlying metabolic environment. And that brings us back to something we've talked about before. Midlife changes the metabolic terrain of your body. Estrogen falls, insulin sensitivity can change, visceral fat increases, muscle mass becomes harder to maintain, and inflammation can rise. So perhaps the bigger story with GLP-1 drugs isn't simply weight loss. Perhaps it's what happens when you change that metabolic environment. But there's a really important catch. We don't know enough yet about what that means specifically for women in perimenopause and menopause. And that's the part I keep coming back to. Because as we covered in the previous video, women in midlife are among the biggest users of these medications. Yet, so much of the research wasn't designed around our particular biology. It means we need to be careful about taking results from a broad population and assuming they'll tell us everything we need to know about women going through menopause. And there are other questions we haven't even touched yet. What happens to muscle? What happens to bone? What happens when you stop taking them? How do they interact with hormone therapy? Those questions all deserve their own videos, because I don't think the answer is simply that GLP-1 drugs are good or bad. They're far more complicated than that. And honestly, that's what I found most interesting when I started digging into all of this. The science isn't giving us a simple answer. It's giving us much better questions. And I think that's what we need more of when it comes to menopause. Not another miracle claim, not another scare story, and that is why I made the channel. Because 5 years ago, I didn't even recognize myself or my body before I found out about perimenopause, and finding the right information honestly changed my life. The pause point is the information I wish I had 5 years ago. So if you're navigating this stage of life too, then I'd love to hear about your experiences. So tell me in the comments, had your doctor ever mentioned the brain or heart side of these medications with you, or was it only ever about the weight? Next time, we're going to talk about something that I focus on a lot. How do you protect your muscle and bone if you're taking a GLP-1 drug? Because losing weight is one thing, but what do you lose along with it? Thanks for staying with me to this point. Please do subscribe, and I hope to see you in the next one.